Good afternoon, everyone. Myself, Dvijen K. Pandya, working as a senior cardiac physiotherapist, grade 2 for at UNMICRC Hospital since the last more than 17 years. Today, my topic is pulmonary function test, interpretation, and physiotherapy perspectives. So, as the name suggests, pulmonary function tests are those tests conducted to measure the various volumes and capacities of the lungs. Now we know that the main function of the lungs is to deliver oxygen to the gas exchanging surface and exhaust carbon dioxide to the atmosphere. The oxygen which has been breathed in by any normal subject is diffused into the blood, and the carbon dioxide present in the blood is exhaled to the atmosphere through the system. The carriage of air through the lungs depends on the patency of the tubes, the consistency of the lungs, and the power of the respiratory muscles. So these are the factors affecting the respiratory process. So in patients with heart or a lung disease, the erosion of physiological reserve eventually imposes limitations upon the activities of daily life. A normal adult is not experiencing or will not experience breathlessness or dyspnea as a resting symptom. But when the disease usually progresses, he or she may feel breathlessness even while at resting or even doing the minor daily living activities. Under these circumstances, the measurement of cardiopulmonary function allows the accurate assessment of disability and of the effect of therapeutic intervention. Lung function test, lung function measurements are made for several reasons. They are useful in describing the lungs for diagnostic purpose and in subsequently monitoring change. So accuracy and consistency are therefore very important, and conventions exist for the procedures of measurement and expression of results. There are standardized procedures for measurement of the lung function which have to be followed. The equipment present in the laboratory has to be calibrated, and the maneuver to be performed has to be explained thoroughly to the patients. The results are obtained and they are compared with the normal values of normal values for that particular subject. In general, a measurement will be accepted only after multiple attempts have been scrutinized and expressed under standard conditions. These are usually the body temperature and the atmospheric pressure. So certain aspects of cardiopulmonary functions can be assessed with some accuracy, but it must be remembered that such measurements are only a snapshot of a component of an organism which is constantly changing and may be influenced by the making of the measurement. It is therefore important to understand exactly what measurement is being made and under what circumstances it is valid before assessing its importance. Given this limitation, carefully made measurements are a valuable addition to the clinical practice. In order to understand the lung function test, there are various volumes and capacities which have to be understood. In health, there are several factors which influence the magnitude of lung function. These include the height, sex, age, and to a lesser degree, the weight and the ethnic origin. Hence, whenever any pulmonary function test is performed, the height, weight, the sex of the subject, that is whether he or she is a male or a female, and the age are taken into account. As a result, assessment of normality can only be made by comparison with the reference values, and the reference values are obtained from study of large numbers of normal people from the relevant population. Hence, for example, if an Asian female is to be assessed for a pulmonary function test, her data, her results will be compared accordingly with the normal range for that particular race. So once obtained, the results can be expressed as percentage predicted or more correctly by comparison with the 95% confidence interval for that value. So test of airway function measure airway caliber and are now well established in clinical practice. Most tests of airway patency examine expiratory function. There are three common methods: the spirometry, which measures the FEV1, that is the forced expiratory volume in 1 second, and FVC, that is the forced vital capacity, the flow volume curve, and the peak expiratory flow. Production of a spirogram from a maximal forced expiration following a full inspiration is reliable and provides the forced expiratory volume in 1 second and the forced vital capacity. To understand pulmonary function test, one must have basic knowledge of the various lung volumes and lung capacities. So firstly, we look at the lung volumes. Lung volumes, there is the tidal volume. The tidal volume is the amount of breath delivered in the lungs during normal breathing. Inspiratory reserve volume. Inspiratory reserve volume is the maximum volume of air that can be inhaled over and above the tidal volume. Expiratory reserve volume. Expiratory reserve volume is the maximum volume of air that can be exhaled after exhaling a normal tidal breath. And residual volume. Residual volume is the volume of air remaining in the lungs after maximal full exhalation. The lung capacities. So inspiratory capacity. Inspiratory capacity is the maximum volume of air that can be inhaled from the resting and expiratory level. Functional residual capacity, it is the volume of air present in the lungs at the end expiration during tidal breathing. Vital capacity, that is the maximum volume of air that can be exhaled after a maximum inhalation. And total lung capacity is the sum of residual volume, tidal volume, expiratory reserve volume, and the expiratory reserve volume. So these are the various lung volumes and lung capacities that we should be aware of before trying to know about the pulmonary function tests. So this particular picture shows the various lung volumes and capacities. For a normal adult, the tidal volume would be approximately calculated as 500 ml, assuming that a normal adult is having a weight of approximately 70 kg. The expiratory reserve volume is approximately 1500 ml. Of course, these values vary from subject to subject, but again, this is the approximate normal value for a normal adult. The residual volume, the functional residual capacity, inspiratory capacity 3000 ml, vital capacity 4500 ml, total lung capacity 6000 ml, inspiratory reserve volume 2500 ml. So these are the various volumes and the capacities of the lung. Spirometry is indicated to detect abnormalities in the lung function suggested by the patient history, physical examination, or related diagnostic test such as chest radiograph. It is also useful to quantify the severity or stage of a known lung disease, to follow the course of a patient's disease and a response to treatment, to assess the risk for perioperative pulmonary complications, to evaluate patients for the presence of pulmonary related disabilities, and monitor the effects of exposure to drugs or toxins affecting the lungs. So these are the various indications. To speak about the contraindications, there are no real contraindications for a PFT test, but the relative contraindications for performing spirometry, they include the unstable cardiovascular status, hemoptysis, which is the presence of blood in the sputum for a patient, pneumothorax, that is the presence of air in the pleural cavity, and any other acute condition that might hinder the test performance, such as nausea or vomiting. So these are the relative contraindications for the PFT test. So the most common test is the forced vital capacity. So forced vital capacity is the total volume of air that can be exhaled during a maximal forced expiration effort. Forced expiratory volume in 1 second, that is the volume of air exhaled in the first second after a maximal forced inhalation. Ratio of FEV1 to FVC, that is the proportion or percentage of FVC expired during the first second of the maneuver. Forced expiratory volume in 3 seconds, that is the volume of air exhaled in 3 seconds after a forced maximal inhalation. Forced expiratory volume in 6 seconds, that is the volume of air exhaled in 6 seconds after a forced maximal inhalation. Peak expiratory flow, that is the maximal expiratory flow typically achieved within the 120 millisecond of start of the forced exhalation. Maximal mid expiratory flow, that is the average flow occurring between 25% and 75% of the FVC. The forced expiratory volume in 1, 3 and 6 seconds are all volumes measured at specific times during the forced exhalation. So these are the various parameters which are measured during the pulmonary function test. If the subject slowly but fully expires to the fullest extent, that measurement is called as a slow vital capacity. The slow vital capacity measurement can help in assessing perioperative risk because it reflects the patient's ability to take a deep breath, cough and clear the airways of excess secretion. In general, SVC values lower than 20 milliliters per kg of predicted body weight indicate an increased risk for postoperative respiratory complications. The SVC also has been used as one of the many measures to evaluate a patient's need for mechanical ventilation for readiness to wean. The most cited threshold is the 15 ml per kg, with lower values indicating inadequate ventilatory reserve and the need for mechanical ventilatory support. Hence, we look at the significance of slow vital capacity as a important parameter to predict postoperative complication and to look for whether the person is ready to wean off the ventilator or not. Peak expiratory flow is often used by patients with asthma to monitor for evidence of bronchospasm. This test is performed regularly using an inexpensive handheld peak flow meter. The results are used to help make self-management decisions and incorporate them into personal action plans. So the subject will use the peak expiratory flow meter, place the device in his or her own mouth and circle it completely and forcefully expire into it so that the readings can be taken. Typically, these action plans identify 80 to 100% of the patient's personal best peak flow as the green zone or the normal. So that means that the no action is needed. 50% or to 80% of the patient's personal best as the yellow zone, requiring self-administration of bronchodilator plus possibly oral steroids, and below 50% of the patient's personal best as the red zone, requiring self-administration of bronchodilator, contacting the doctor and possibly going for a hospital visit. Hence, peak expiratory flow is a highly effort-dependent measure and is not particularly useful in diagnosing pulmonary dysfunction, but it is commonly used by patients with asthma to monitor the severity of bronchospasm and its response to treatment. Maximum voluntary ventilation. Maximum voluntary ventilation is the maximum volume of air a subject can breathe over a specified period of time, usually 12 seconds. The 12-second volume then is multiplied by 5 to extrapolate what could be achieved in 1 minute with the value expressed in liters per minute. Maximum voluntary ventilation is affected by the strength of the respiratory muscles, the compliance of the lungs and thorax, inspiratory and expiratory airway resistance, and patient motivation and effort. Reference values vary widely, ranging from more than 170 liters per minute for the young adult male to less than 90 liters per minute for elderly females. Maximum voluntary ventilation can also be estimated by multiplying the measured FEV1 by a factor of 40. It is used to assess conditions in which ventilatory capacity may be impaired by different mechanisms. The maximum voluntary ventilation is used to assess conditions in which ventilatory capacity may be impaired by mechanisms differing from those affecting the FEV1. For example, patients with neuromuscular disorders exhibit much larger than expected decreases in their MVV relative to that predicted from their FEV1. The MVV is also used in exercise testing to estimate a subject's breathing reserve. There are two major components to spirometry quality assurance: equipment calibration and technique validation. Hence, all the equipment which is being used for pulmonary function testing should be properly calibrated and regularly checked so that the readings taken are error-free and reliable. The technique validation to validate the technique, the maneuver must be properly explained to the patient. The patient must be made to sit comfortably, place the mouthpiece in his or her mouth. The maneuver should be explained to the patient or the subject by the therapist. It should be performed once or twice so that there is no doubt, and the proper readings should be taken. FVC maneuvers are highly technique dependent. For this reason, accurate measurements require proper patient performance of the procedure. So, providing clear instructions and eliciting a maximal effort are the keys to assuring a valid FVC maneuver. So, this particular diagram shows the normal flow volume loop. So, we look at the PEFR. The PEFR is the peak expiratory flow. So, this is the highest point in the expiration of in the expiratory curve of the patient. And there are again there are two loops. First is the expiration loop and the second is the inspiration loop. So, firstly, we ask the patient or the subject to place the mouthpiece in his or her mouth, encircle it tightly around the mouth so that there is no air leak. In case the patient is breathing through the nose, the nose clip should be placed so that the subject does not breathe through the nose. Then we ask him to fully inspire to the maximum possible level and then fully expire. The first second of the during the first second of the expiration, the maximum air flow should be taken. Hence, it is so that we can receive the first expiratory volume in 1 second. And the patient should exhale for an approximate duration of 6 seconds and then again take a maximal inspiration. So that is how the flow volume loop, which is being shown in this figure, will be completed. Again, one more diagram which is depicting the slope. So these are the parameters measured on a typical volume versus time spirogram. The FEV1, the FEV3, FEV6 and all the volumes measured at specific times during the forced exhalation. So the peak expiratory flow is computed as slopes on the spirogram. So these are the so we can note that the maximum volume of air is expired within the first second. Approximately 75 to 70% of the air in the lungs is expired in the first second and around 80% is expired during the 3 seconds. But the maneuver is continued till 6 seconds and then followed by full inspiration. In addition, the clinician must be able to recognize and correct any observed errors in the technique. The goal or the target is to obtain at least 3 acceptable and error-free maneuvers that are repeatable. An acceptable maneuver must be free from artifacts, exhibit a good and forceful start, and achieve complete exhalation. To ensure repeatability, the therapist must confirm that the key volume measures, that is the FVC and FEV1, are free of significant variability. In case the subject is not able to understand the maneuver and he or she is not able to perform it, that is, if no acceptable maneuvers can be obtained, results should not be reported. Rather, all specific errors encountered should be documented. Only if 3 acceptable maneuvers can be obtained, meeting both the repeatability criteria, should results be reported. If the initial results are acceptable but are not repeatable, additional testing should be conducted until either the repeatability criteria are met or the patient cannot continue. All reports should contain the therapist's overall assessment of test quality. Assessment involves comparison of the patient's data with reference values generated from samples of healthy subjects and a review of the applicable plots. The pulmonary function community has adopted plus or minus 2 standard deviations from the predicted mean as the normal reference range, with plus or minus 2 standard deviation encompassing 95% of the values in a normal distribution. One can define the boundaries of this range as cutoff points outside of which the results are abnormal. So these cutoff points are called the lower limit of normal and, if applicable, the upper limit of normal. After ensuring the test results are valid, 3 acceptable maneuvers with 2 of them being repeatable, one compares the patient's FVC, FEV1 and the FEV1, FVC to be the predicted reference ranges. In case if all the 3 values fall within the reference range, the results are deemed normal. If, however, the FEV1 is reduced and the FEV1 to FVC ratio falls below its lower limit of normal, an expiratory flow limitation exists and the patient is classified as having an obstructive ventilatory defect. Hence, when there is a flow related defect, it is classified as an obstructive ventilatory defect. The severity of obstructions is quantified according to the magnitude of reduction in the FEV1 by FVC ratio. The other major possibility is a reduced FVC, normal or reduced FEV1, and the FEV1 or FVC ratio above the lower limit of normal, normal or higher than normal. And FEV1 or FVC above the lower limit of normal rules out an obstructive impairment, but the presence of a reduced reduced FVC suggests that the patient may have a reduction in lung volume, which would be classified as restrictive ventilatory impairment. An obstructive ventilatory impairment is characterized by reduced flow as evident by an FEV1 or FVC ratio lower than the predicted lower limit of normal. A restrictive ventilatory impairment is characterized by decreased lung volume. Hence, when there is a flow related defect, it is an obstructive impairment, and when there is a volume related defect, it could be a restrictive defect. Interpretation is enhanced by review of the graphic plots obtained by spirometry. After the basic pattern is identified, additional testing may be indicated. If the spirometry results indicate that the patient has an expiratory obstructive impairment, the doctor typically will want to determine whether obstruction is reversible with treatment or not, that is, whether it responds to bronchodilator therapy or not. So this figure shows the forced vital capacity curves of a normal subject, a subject having an obstructive impairment and a restrictive impairment. So we look at this obstructive impairment and we see that in the obstructive impairment, the subject will take longer than expected time to empty the lungs. In a restrictive defect, the subject will definitely empty his or her lungs at a normal time or a time earlier than expected, but the volume will be reduced. So these are the figures depicting the normal, obstructive and restrictive disorders. The force vital, these are the figures, beg your pardon, this is the figure showing the force vital capacity of a normal subject, a subject with an obstructive pattern and a subject with a restrictive pattern. So we look at, so if a patient, beg your pardon, if a patient is having an obstructive defect, we have to look for the reversibility, that is whether the treatment, whether the subject shows any changes to bronchodilator therapy administration. So this is accomplished by measuring spirometry values before and after administration of the selected bronchodilator. Normally, the baseline spirometry should be conducted at least 4 hours after any prior use of a short-acting beta agonist and at least 12 hours after any administration of a long-acting bronchodilator. so that the resting values are obtained and these values are normal. Now, if after the bronchodilator administration the FEV1 or the FVC increases by more than 12% and at least 200 ml, the obstructive impairment is considered reversible. A lesser response indicates that the airflow limitation is not reversible. Hence, we can assess whether the obstructive impairment is reversible or not by this performing the PFT test prior to bronchodilator administration and after bronchodilator administration. A reduced FVC in the presence of a normal or high FEV1 or FVC suggests that the patient may have a reduction in lung volumes. However, this pattern can occur among patients who fail to completely inhale or exhale during the maneuver. For this reason, if there is a confirmation, for this reason, if there is a reduction in lung volume and the presence of a restrictive disorder, the doctor may suggest measurement of static lung volumes, that is the FRC, functional residual capacity, residual volume and total lung capacity. Moreover, if it is suspected that the restrictive condition is due to an interstitial disease process, most doctors will also request a diffusing capacity study. So this is the image which shows the changes in the lung volumes and capacities for a restrictive and obstructive subject having a defect of restrictive pattern or an obstructive pattern. So the interpretation of the patient's flow volume loop can aid in interpretation, especially in identifying the presence and the location of large airway obstructions. This particular slide shows 6 examples of flow volume loops representing distinct patterns of abnormal function. So disorders causing generalized expiratory obstruction like asthma and emphysema mainly affect the maximal expiratory flow volume curve, with both exhibiting a reduction in the peak flow and a forced expiratory volume at the 50%. We also note that the maximum expiratory flow volume portion of the loop on the patient with emphysema is markedly concave, and the position left of the normal loop, indicating greater flow obstruction at lower lung volumes as well as air trapping and hyperinflation. On the other hand, a patient with restrictive ventilatory impairment typically produces a flow volume loop with same shape as normal, but one that is markedly narrower on the volume axis, consistent with a smaller FEC. The bottom 3 flow volume loops portray different types of large airway obstructions. The variable intrathoracic obstruction loop reveals a markedly reduced peak flow on expiration despite near normal inspiratory flows. This typically is the result of expiratory flow obstruction in the large airways, and as may occur with tracheomalacia or tumors of the trachea or bronchi. The opposite pattern is seen in variable extrathoracic obstruction, that is reduced inspiratory flow and relatively normal expiratory flow. Vocal cord dysfunction and laryngeal edema are common causes of variable extrathoracic obstruction. An equal reduction in inspiratory and expiratory flow suggests a fixed large airway obstruction. So causes of fixed large airway obstruction include tracheostosis, tracheal tumors, and foreign body aspiration. So these are the various figures indicating various types of disorders. If a patient has reduced lung volume, it may indicate static lung volume measurements, because static lung volume measurements can confirm the presence of a restrictive ventilatory defect. Static volume measurement. So static volume determination involves measurement of resting lung volume or FRC. If the FRC is known and the inspiratory capacity and expiratory reserve volume also are obtained by spirometry, both the residual volume, that is the FRC minus the expiratory reserve volume, and the total lung capacity, that is the FRC plus IC, can be computed. In general, static lung volume testing is performed in the pulmonary function laboratory. So the indications for static lung volume measurements include to confirm a restrictive disease pattern, low FVC, normal or high FEV1 by FVC ratio, to assess the impact or response to medical or surgical interventions such as lung volume reduction, lobectomy, lung transplantation, and radiation or chemotherapy, and to provide an index of gas trapping. Requires comparison of FRC by gas dilution to plethysmographic thoracic gas volume. Contraindications against performing static lung volume determinations are essentially the same as those previously described for basic spirometry, that is the unstable cardiovascular status, hemoptysis, that is presence of blood. Hemoptysis means presence of blood in the sputum. Pneumothorax, that is presence of air in the pleural cavity. NAR, any acute condition that might hinder the test performance such as nausea or vomiting. The methods for static lung volume measurement. So there are three different methods used to measure the FRC: closed circuit helium dilution, open circuit nitrogen washout, and body plethysmography. These are three separate techniques which there is no study to suggest the superiority of one over another. Hence, the test which is available will be conducted on the patient. So closed circuit helium dilution. So closed circuit helium dilution test is based on the principle that if a known volume and concentration of a gas is added to the patient's respiratory system, it will be diluted in proportion to the lung volume to which it is added. Helium is used because it is an inert gas and it is not significantly absorbed from the lungs by the blood. In normal subjects, equilibrium takes about 7 minutes, so that the oxygen must be added and carbon dioxide removed from the system to keep the gas concentrations constant and prevent hypercapnia. After equilibrium is reached, the FRC is calculated as follows. The FRC will be initial helium concentration minus the final helium concentration divided by the final helium concentration multiplied by VAP and minus VD max. So in this case, the VAP is the apparatus volume, that is the volume in the spirometer and connecting tubing. VD max is the dead space of the mouthpiece of the breathing valve with results corrected for body temperature and pressure condition. That is, the dead space of mouthpiece and the breathing valve will be subtracted from the readings. Because helium does not reach areas of the lung distal to any obstruction, the measured functional residual capacity reflects only functional lung volume, that is the portion of the lungs which is in open communication with the airways. The volume of any air trapped in the lungs is not measured. There is another test which is the body plethysmography. In the body plethysmography, the patient sits inside a rigid box-like enclosure and breathes through a pneumotachometer equipped with a pressure transducer that measures pressure changes at the mouth. The internal box pressure also is measured by a sensitive pressure transducer calibrated to reflect volume changes inside the enclosure. After the patient completes a normal exhalation, a shutter in the pneumotachometer closes, occluding the airway. At the same time, the patient gently pants about once per second against the occlusion for 2 to 3 seconds. During the panting maneuver, changes in mouth pressure are recorded by the pneumotachometer's pressure transducer, with the pressure at times of zero flow equivalent to the alveolar pressure. Simultaneously, as the patient compresses and decompresses the gas in the lungs while panting, the box pressure transducer measures the corresponding volume changes as the The box pressure transducer measures the corresponding volume changes as the thorax expands and contracts. Thus, we have a starting volume, the unknown starting volume and the starting pressure, alveolar pressure before inspiratory phase of pant, as well as the ending volume and ending pressure, alveolar pressure at the end inspiratory phase of the pant. So according to Boyle's law, we know that P1 multiplied by V1 is equal to P2 multiplied by V2. Based on this formula, V1, that is the unknown FRC, the functional residual capacity, can be computed as V1 equal to V2 multiplied by P2 divided by P1. Expressing pressure and volume as changes from baseline, so the FRC will be delta V divided by delta P multiplied by P2. Since the panting creates only small pressure changes around barometric pressure, P2 is assumed to be equal to PB. So the FRC will be equal to delta V divided by delta P multiplied by PB. Thus the FRC equals the slope of the changes in the thoracic volume measured as changes in the box pressure versus the changes in the mouth pressure during the panting maneuver as portrayed on the computer display. The third test is the open circuit nitrogen washout test. The benefit of the body plethysmography test is that here the volume of air trapped in the lungs can be measured. Hence, it has a slight advantage over the helium dilution test as well as the open circuit nitrogen washout test. Open circuit nitrogen washout test. In this test, the patient breathes about 100% O2 with expired nitrogen concentration continuously monitored. The test continues for at least 7 minutes or until all the nitrogen is washed out of the patient's lungs. Washout is just complete when the nitrogen concentration is less than 1.5% for at least 3 consecutive breaths. With the total volume and concentration of exhaled nitrogen known and the knowledge that the air originally in the patient's lungs contains 78% nitrogen, the patient's FRC is computed as follows. FRC is equal to the volume of nitrogen washed out minus the volume of nitrogen from the tissues divided by starting nitrogen concentration minus the ending nitrogen concentration. The volume of nitrogen washed out during this test is determined either by collecting the entire volume of expired gas and measuring its nitrogen concentration or by computer compilation of the breath by breath volume and the nitrogen concentration, nitrogen percentage. Nitrogen percentage. The volume of nitrogen excreted from the tissues is estimated by equation based on the patient's body surface area. Same as with helium dilution, the volume measured by nitrogen washout is limited to that in open communication with the airways. For this reason, in the presence of significant air trapping, the nitrogen washout technique will tend to underestimate the actual FRC. Again, we have the diagram of a PFT flow volume loop, that is the normal one, the obstructive one and the restrictive one as discussed earlier. These are again different diagrams explaining the different PFT flow volume curves of different subjects. One with a normal subject, one with the third one is for a chronic obstructive disease. The fourth one is for a subject having a fixed large area obstruction. The sixth one is for a patient with having a restrictive disease. So these are the various diagrams for a flow volume. These are the various diagrams or the flow volume loops of different types of subject having different types of disabilities, different types of PFT diseases, beg your pardon. So the value of lung function test lies in the description of pathophysiology, which may give a guide to diagnosis. PFT is one of the several tests which can be helpful to arrive at a patient's proper diagnosis. Once a baseline has been established, changes in function can be used to assess progress with natural history or treatment. The usual description of these tests disease requires the combination of spirometry, lung volume and gas transfer measurement. Coming to the last part of the lecture, that is for a physiotherapist's perspective. From a physiotherapist's perspective, PFT tests can provide vital insights into the nature of a patient's lung disease and hence the physiotherapist can plan his or her treatment accordingly. If a patient has any abnormal findings in PFT report and he or she is planned for surgery, the physiotherapist can plan his or her treatment accordingly. As for example, if a patient has a COPD or obstructive pattern in his or her PFT, the physiotherapist can look for the reversible defect in the patient and plan his or her treatment accordingly, so that the patient, before being taken for surgery, is in a fittest possible state. PFT tests provide valuable diagnostic aid to arrive at a patient's diagnosis, enhance suitable interventions for patient treatment, and hence suitable interventions for the patient treatment can be planned for the best possible recovery. It can be useful for perioperative status, and it can provide valuable insights to arrive at a diagnosis of a patient whose previous lung disease are not known. With this, I conclude my lecture on PFT. I heartily thank Dr. Ayesha Madam for her support and guidance in performing this lecture. I also heartily thank all the higher authorities of my hospital for giving me this opportunity. In case I have not mentioned any higher authority, I beg your pardon. So I thank all the higher authorities and my department for helping me with this lecture. Thank you.